Just give everyone a minute or two left, and then we'll get going. Standard housekeeping for everyone. I'll ask you to keep your microphones off. We will have time for questions at the end of the panel discussion, though. Oh, you have no sound. Is anyone else having issues with sound?
No, it's all good from my end.
Might just be you, Karen. Right, we'll have a few minutes. I'll let them troubleshoot at that end. Brilliant. I might get going, and I will give Karen a few minutes leading up to this before I ask her to join our panel. So give her a bit of time. But thank you all very much for joining me this morning. I really appreciate it. This is our second meeting for the year, and this is quite an important one. I think we can all breathe a bit of a sigh of relief that the New Aged Care Act has actually been postponed by a couple of months. But I figure this just gives us all the more time to prepare in advance. Before I begin today, I do wish to pay my respects to the traditional elders and custodians of the lands that we're all joining on from today, and I pay my respect to their elders past and present. Before I introduce today's topic and our panellists, I did want to give you a quick update from Palliative Care Victoria. So in the last fortnight, we've actually released multilingual editions of the Being Prepared as a Family Decision Maker booklet. These are printed, available to be sent to your service for free from us, or you can download the PDF copy from the website. We will send information about these resources in our thank you email at the end of this discussion, but just promoting them, they've been a fantastic addition to our catalogue. Each edition was actually done in collaboration with the community groups that are featured, and they had a fantastic day of photo shoots and sharing knowledge and stories. So we really do value these being out into the community. Second thing I did want to raise is, I'll ask everyone to pop themselves on mute if that's okay, just to ease the second thing I wanted to raise is that Palliative Care Victoria is currently preparing for next year's state election. Does seem like it's a while away, but time will sneak up on us very quickly. What this means from our community is we are just reaching out for your stories. We would love to hear your feedback, the good, the bad, the ugly. We want to be able to share with the government exactly what the true state of palliative care is in Victoria, as well as some well-considered strategies on what we think can actually be put in place to improve it. We will send information about how you can share your feedback, and we do really value everyone's contribution. The last piece of housekeeping I did want to raise is that following this meeting, we actually do have an education session by our very own Victoria Palliative Care Consortia, talking in depth about the New Aged Care Act and what it will mean for providers on a more tangible level. I will send the details about that discussion. It is free to join. It has been facilitated by our palliative care and aged care specialist, Carol Barbara, out in the Gippsland Consortia. And we highly encourage people who want to know more about the practical implications for their service to participate in that conversation. It's now my pleasure to introduce today's topic. So it's no surprise to many of you here that we are waiting on the upcoming New Aged Care Act, which has been postponed to the 1st of November. This is for residential and home care providers across Australia, where they would transition into the new New Aged Care Act, as well as the new strengthened standards. Under the new Act, the right to access palliative care and end-of-life care is now explicitly highlighted as a fundamental component of high quality and safe care. And this addition was included following recommendations from the Royal Commission, as many of you know, who emphasised that palliative care shouldn't be an optional afterthought in aged care. And instead, they acknowledged that it should be part of the core business of aged care and holistic person-centred care. To support these requirements, the outcome 5.7 of the Act of the new standard, will take effect and specifically address palliative care and end-of-life care providers, asking them to recognise when an individual is approaching end of life, support individuals and families through advanced care planning, and end-of-life care planning, and ensure timely access to the necessary services. For many services, implementing an effective model of palliative care in accordance with standards is actually going to be quite a scary prospect. And this is compounded with the additional changes that they're needing to put in place. So what we are looking to do as a sector is better support our services to be able to implement these changes seamlessly and make it their business as usual. In this vein, I'm now going to introduce our speakers in no particular order today. We have three incredible guests. Our first is Tony Arndell. She is the National Engagement Manager for the End of Life Directions for Aged Care program, or LDAC, as many of you know, run out of the University of Queensland. Our second speaker is Karen Conti. She was formerly the Managing Director for the Home Instead out in the Melbourne Outer Northeast. But since the rebrand of Home Instead to Davida, she has now taken on a role as a business development manager and specialist palliative care support. Our final guest is Danny Campbell-Manley, who is our state manager for both Victoria and Tasmania for Ageing Australia. And I welcome all three of these incredible minds to our conversation today. And thank you for joining. So, as previous meetings, we will save questions till the end. Do feel free to pop them in the chat though as we go, and we will answer them at the end of the conversation. The first question I'm going to pass over to you, Danny. So we are very excited that there's been a bit of a delay, but we've still got a bit of work to do. The obvious benefit of the additional time is that it gives us greater opportunity to prepare for the road ahead. So with that said, what can specialist palliative care services do to better prepare our aged care services, both in residential areas and in the home care space, leading up to these new changes?
Yeah, thank you, Tiffany. It's lovely to be here with everybody today. And indeed, yes, a little bit of a breathing time, but it's not a lot. It's just a little bit of breathing time. And I think, as you've highlighted, Tiffany, it's not that we didn't have palliative or end-of-life care under the current standards that will take us through to the 31st of October before the new ones kick in. But yes, they were a little bit more ambiguous. So certainly people should already have elements that they're used to implementing, whether it's be for that person, for that emotional or spiritual and cultural element, or under care, that timely coordination of, and making sure that they've had that appropriate workforce, which they'll need to definitely continue on to. But Tiffany, you're so right. It's very explicit now under 5.7. So I guess that really brings us to, well, how detailed is it? It's really detailed. So it's talking a lot about not only do we need to make sure that we prioritise comfort and dignity and responsive symptom management, but someone's going to then expect that the provider is able to demonstrate that. So if it's explicitly said, then when someone comes along to make sure that we are meeting those needs, an independent assessor, then we're really going to have to show that in quite a level of detail. And then along with that, we've still got those same spiritual and cultural and psychosocial needs that we need to be meeting as well. But there's newer things that are sort of said differently to anything we've had before, like that access to medicines and specialist equipment, and I guess those clinical expertises and things like that can be really tricky. So even if that comes down to have, say, for residential care providers, have they considered an IMPRESS system before? Potentially they might have had that in COVID. We know that licensing and getting licensing for the IMPRESS systems are not altogether easy. So in the lead up, we have flagged that with the Department of Health Victoria, because there's sort of two different departments within the Department of Health, which is a big organisation. So we're saying things like that are something to consider, because if you're meant to be having those really timely responses, what would that look like? We have that now, and we've always had that obligation, but it's not been as explicitly written as that. I think in terms of we're needing under this standard to have people really informed and supported and their families. So to have it really clear that the families and supporters of those individuals need to be given some guidance and assisted. I don't know that we've really had that as well laid out before, but nor have we had laid out that we have to have a reduction in unplanned hospitalisations. We know that as an industry we've wanted to do that, but we haven't really always explored that in that we have to show someone how we're doing that. So I think things like the Victorian Virtual Emergency Department, in-reach programs and how we're utilising those are key. I think what I'd say, Tiffany too, and to everyone online, is VVED has now a whole separate arm just for aged care. So it does show that how important our industry is, that someone's gone, okay, well, yep, we need to cater to the general public, but we want to have a whole arm just dedicated to aged care. And so I think things like that, we will be really expected to show how we're demonstrating and doing that, along with the advanced care planning. So I think that all leads us into that we will really rely on those specialised services to give us some really useful tools in practical education, what the deterioration looks like, what a trajectory of deterioration might look like for that individual. There's often a confusion about end of life versus palliative care. So what is that real end of life going to potentially look like for that individual? And we'd look to, I guess, coaching and mentoring, because to meet care minutes and the demand, we have not always had the opportunity to educate some of our newer registered nurses coming in. They're really busy trying to meet care minutes, do a lot of on the ground workforce issues that we've been needing to do through even just really difficult times leading out of COVID, that we've gone, let's just get numbers in. There's been a significant expectation of increasing sort of qualification on the ground. And so that's particularly so for residential care. So what's that going to look like? So I think anything that assists us with that mentoring, education, supervision, drawing on things like even in the moment, like VVED and in-reach programs, they offer great guidance opportunities for us as an individual. But anything that helps support us map those changes from those current, say, 3 dominant standards to that explicit outcome on really, really critical, and accessing those anticipatory medications as well, because that's all sort of explicitly written in as well. So that's quite a lot to get us started, I think.
I think that's a fantastic response. And I think I really hear what you're saying on that transparency of messaging. I think particularly in our specialist palliative care services, we do see quite a variation on the referrals that come from aged care. And I think it very much then comes down to us as a sector looking at meeting the services where they're at. If they're not appropriate referrals, do they know why? And how can we help them improve that? When we are looking at the services that we have as a sector to support aged care, are they being promoted well? The IMPREST is actually quite an interesting topic, because we know our primary health networks have been quite active in trying to promote engagement in this program. But where are we dropping the ball if it's not been universally picked up? Thank you very much. I will check online to see if our second speaker, Karen, is in the room.
Yep, I'm here.
Ah, brilliant. You come up on my screen. Karen, this one is for you. So under the new act, the end of life classification can only be accessed by once, meaning that clinicians and service providers will want to be very confident about the person's prognosis before they approach the government for that funding. But some illness trajectories, as we all know, are not that straightforward, and deterioration can be harder to identify in some cases, particularly for our non-malignant population. In that setting, are we at risk of a person not being assessed for the end-of-life care funding at all, not having that access? And how can we prevent these residents from falling through the cracks?
Thanks, Tiffany. Yes, so I'm focusing on home care, so clients or participants, that will be the new name, so not residents for us. But you're right, under supported home, can everyone hear me okay? Because I had some audio issues. Okay, great. We only have one bite of the cherry, and we know that prognostication in anybody is quite difficult 3 months out, but particularly in older, frail people, it's quite difficult to predict. So we have access to the end of life care funding for the home care client, but for a 12-week period, we can extend that to 16 weeks if the person is still with us after 12 weeks. The $25,000 that's talked about is a great start, but it's not in addition to their current funding, it's instead of. And that's, we've identified already that there's going to be quite a number of challenges in utilising this funding, but I'm still trying to be very positive about it and think, as Danny said, at least it's a recognition, and a very overt recognition, that palliative care is an important part of the aged care sector, whether it's residential or home care. And, obviously the government are wanting to keep people out of hospital and dying at home if that is their choice, and out of the acute care setting, and that benefits everybody. But it is going to be quite a challenge. I think that we might see an increase of people who haven't accessed supported home in the past, who are over 65 and have been reasonably well and not needing care at home, and now have a terminal diagnosis, and they might be sitting in a palliative care unit and thinking, I'd rather be home, but I don't have enough support. And I think the access to that money then is going to be very beneficial to them. But if we think about our typical quite advanced client in the community who might have very advanced dementia, they're already on the highest classification, then that $25,000 isn't going to be much more than what they're already on. And I did crunch a few figures and worked out that they'd end up with about $458 a week extra. So, it's not going to make a huge deal of difference to our highest classification clients, but it'll make a difference to people who are either not accessing it at all or on a lower classification. But we will be using some tools. Part of the criteria for accessing the end-of-life care funding is that they have to be on a Karnofsky of 40 or less, which means they're in bed more than 50% of the time. And there are some other tools such as SPIC tools and things like that that we can try to use to determine the prognosis, but it's going to be difficult. I am in the process of developing a crystal ball, so that will not be a problem in the future. As in palliative care, we've always wanted crystal balls. But I think it'll be also about really upskilling our staff in the non-specialist area of home care to really understand what deterioration looks like and when to escalate that and to refer. Another challenge for us is the fact that we don't always have access to a specialist palliative care service. And so, when we're thinking about an older person who's dying without a lot of symptom management issues, they may not be accepted in a specialist palliative care service. And so we need to have our staff skilled and resourced enough to be able to manage those sorts of clients at home. So it's going to be quite a challenge. We already do some of it in the home now, but I think we need to really ramp that up.
No, I think that's fantastic. Thank you for developing this crystal ball. I think even beyond the aged care sector, we would be very welcome. It has been raised by people in the community that miscommunication and misunderstanding about the involvement of specialist palliative care within the end-of-life care packages, both in the home care space and in residential aged care. And we have had questions about people in the assumption of part of that funding amount being used by specialist palliative care, or there been some reliance on having to have involvement of a specialist palliative care service to receive the funding. So I think there is definitely that piece of communication that we need to look at on making sure that the mystifying things have been sorted out before we get to the funding.
Yeah.
My next guest, Tony, you've been coordinating the LDAC program for some time now. And recently they've extended their toolkit of resources to include a package that prepares for the new aged care standards and the linkages program particularly. So one of the key components of the linkages program is it integrates you with specialist palliative care services in primary care and aged care. And the partnerships are designed to optimize the capacity of services to provide the best possible care and end-of-life care in a timely way. A number of these services have already used them in Victoria, and we're now going to look at what do these look like in practice. So we do promote them as part of our bread and butter at Palliative Care Victoria, but I think it's very helpful for us to give an understanding of what it actually looks like in the care delivered to the person and the outcomes for the resident.
Wonderful. And thank you very much, Tiffany, for the opportunity to be here today. I can see quite a number of familiar faces who've been on the linkages journey with us before, which is fantastic. For those of you who maybe don't know about LDAC or are less familiar with it, we're delivered by a national partnership consortium. So that's consisting of 3 universities, QUT, where I'm based in Queensland, Flinders and UTS in Sydney, but also 4 peak body partners from aged care, primary care, and Ageing Australia and Palliative Australia are obviously 2 of those really important partners. So we're bringing that depth of insight in terms of the combined wealth of experience in the industry as well as combined resources. So really team collaboration and working together to improve quality of care is really what's in our DNA to really improve those quality outcomes. At LDAC, and particularly so with the linkages program, we advocate for a whole of team approach to improvement. And that means both the internal team within the service that we support on the linkages program, as well as that wider community of partners that are critical to the delivery of high quality, really person-centered care. And I really want to acknowledge that many of the organisations, as Tiffany's just mentioned on the call today, have been part of that journey and have really achieved some incredible outcomes that continue to inspire not only just us as a team, but also new services who might be interested in embarking on their own LDAC linkages journey. And there's a myriad of examples that I could probably choose from, but I'll highlight a few today. But if you are looking to sort of deep dive into a few more of those, they are available in terms of some great impact videos from previous participants, as well as our case story booklet on our service development section of our website. So essentially, in a nutshell, linkages is all about a quality improvement program that we tailor by working with the local service at the local level. So it's important to note that the model we use is tailored because we work with services for their unique local needs and work to really conduct an activity that we call service mapping. So we work out who the individual service is currently partnered with. And I should note that we work with both home care services as well as residential aged care facilities. And we work at that local level first to identify what existing partnerships may stand, how do we strengthen those existing partnerships, and what are new ones that we could look at in terms of a target future state to really building that person-centred integrated care. And we're looking also as part of that linkaging process to improve capacity and build capability across their workforce. One service that we work with that comes to mind, and again, I'll for anonymity's sake, we are a research program, so we're governed by ethics, but a lot of these wonderful services, these models or these activities and initiatives have been, I would say, replicated across the state. And I think Victoria really leads the way, I'd like to say, in terms of being integrated and very, very well connected. One service that I think that does come to mind would be, it was an organisation that had multiple residential aged care facilities enrolled with us. They were very keen to strengthen their connection with local specialist palliative care organisation wide. And that was not only to access that clinical consultation support, but also to really leverage the absolute critical bonus of leveraging education and mentoring opportunities. So they built trust and clarified roles and responsibilities from the get-go. And that was really establishing what their role as an organisation was in delivering generalist palliative care, as well as how to really effectively refer to and engage with GPs and the specialist palliative care service as and when required. This involved really setting up a roundtable meeting to really understand roles and responsibilities, and for the services themselves to understand really the unique needs. There was also an audit process. So we have a number of audit tools that we use. One is an organisational level audit to understand really what are the enabling structures, policies and processes you have in place to stand up really great holistic palliative care, and also a personal learning needs assessment. So to really understand from the workforce's side of things where those learning gaps are and how particularly specialist pal care could help support that education, that support, that supervision. A number of key initiatives also included implementing multidisciplinary needs rounding, which was led by the specialist pal care team and has been a really critical element in their success, as well as establishing a network of palliative care and advanced care planning champions within the organisation. Those champions were then mentored by the specialist pal care team, and a number of those key team members were also identified to attend what we call a reverse pepper placement. And I'm sure many of you, I don't need to explain what that is, but it really gives that wonderful opportunity to immerse yourself into the specialist pal care world and to shadow and observe and get that excellent specialist care and support from the specialist pal care team. So the needs roundings really also helped provide education to the wider multidisciplinary team, and their working group included both clinical and non-clinical team members, as well as allied health care workers and RNs. The other capacity building activities included upskilling of staff with shared education, on-site aged care pepper workshops, as well as education sessions held with local GPs in place, and the GPs themselves were provided with a palliative care information folder. The specialist pal care team also consulted on clinical issues and provided, as I said, that mentoring to aged care staff, but they were also able to host a resident and family education session on advanced care planning and palliative care. The feedback from those sessions really allowed the service to continue to provide that person-centred approach to care, because this instigated much richer discussion in terms of the residents' advanced care plans and knowing really what mattered most to residents and their families. That helped to therefore continually evolve and monitor the care approach or the palliative care strategy of the organisation to maximise the quality of that care experience. And they also implemented a palliative care trolley with help from the specialist pal care team. Another service that we worked with really was catering to residents from diverse cultural backgrounds who also had a diverse cultural workforce. And so they were really keen to establish a robust and holistic framework. They used the LDAC care model to do that, which advocates heavily on the profound impact that partnering to deliver integrated care can have on outcomes. And this service had a dedicated palliative care CNC who acted as the lead palliative care champion and coordinator. So that really helped with that consistency and continuity of care, also with hospital transitions as well as with referrals. And this really helped building those collaborative partnerships with the local specialist pal care team in a proactive way. They had found previously it had been fairly reactive as and when needed, rather than building that mutual partnership from the ground up in terms of educating about the services they provide and where they needed support from specialist pal care. They also suggested including a resident representative on their palliative care team champion network. So again, they were getting feedback from the resident community about how to really guide and design person-centered tailored care. And this also really helped with identifying the community leaders that were also involved in some of the family and resident education sessions, who potentially in a previous part before joining LDAC, there was a lot of cultural taboos really when speaking about death and dying in a culturally safe way. So this led to educational sessions delivered in partnership with GPs and the specialist pal care team on advanced care planning, which really helped to increase access to specialist pal care team for those from a diverse background, which often face barriers to accessing palliative care. And finally, I'd just like to say there was one of our services who, again, this was a number of years ago now, but really had a wide-ranging effect on the region. And that was really about the premise around experts saying that good palliative care or good collaborative palliative care is proactive rather than reactive. So this was a community roundtable that was set up with the support of the specialist pal care team, hospital-based specialist pal care team, as well as community and the aged care service, inviting the GPs, the primary health network, all together around the table to strengthen communication and truly understand their roles and responsibilities for everyone within that network. This also involved understanding how to strengthen communication and referral pathways, and all partner agencies had to sign up and agree to standardise information exchange processes and how they could be utilised. This resulted in, again, a very effective regional referral operational pathway. So not so much the clinical side of things, but more of how we're going to have more collaborative ways of working from an operational standpoint in a more efficient and effective way. But it also really helped organisations learn more about each other's organisations. So there were less gaps in terms of understanding their needs, their strengths, and service delivery, quality improvement initiatives. So they ended up really utilising each other's services far more effectively just by having that roundtable open discussion and strengthening those communication frameworks. So that's probably a lot, but I'm super proud of the incredible work that our services have been doing on linkages. So could probably talk forever, but that's probably my time overgone there. Sorry, Tiffany.
No, that was a fabulous elevator pitch. And honestly, that's exactly what you need for this sort of discussion. It's really that practical, this is what you can expect if you go down that rabbit hole. I really like the fact you addressed the regional concerns as well. That is one of the issues that we really face in palliative care, the postcode lottery and the service delivery that varies significantly between our regions to our metro services. I do appreciate, in the interest of time, we will have questions at the end, but if there are questions about the linkages program or any of the LDAC resources, please reach out. We will obviously send them over to Tony, or you can email her directly. It is a fantastic program, and I think what I like the most is that it puts the onus on the service really stepping up and taking accountability for that development. And by them building the relationships, them reaching out to services and saying, we are proactively making these changes, we need you to come along for the ride. I think it spreads the load a bit, because often, particularly from the peak level and from some of those organisations who support residential aged care, we always feel like we're leading the horse to water. Whereas I think that if we have this grassroots approach, we might actually get much better engagement.
Absolutely agree.
I'm going to then turn back over to Karen and put the spotlight on you to say, so DaVita have newly introduced your role. It is the first time they've had the national lead for palliative care across the service to look at developing palliative care in the delivery of the home care space. Not all home care services are going to be delivering palliative care under the new changes. We have had a lot of feedback from home care services out in the community saying they are not prepared and they're a little bit overwhelmed, and they basically want to see best practice before they go down that rabbit hole themselves. So would you mind being generous enough to give us a bit of an overview of what you have planned for this role and what it involves, and how you're using it to prepare your service to deliver end-of-life care to the community?
Sure. Having not actually started the role yet, but I'll tell you what's been, rolling around in my little brain when I've got some headspace. So as Tiffany said, so my background is specialist palliative care. I've worked in specialist palliative care services for quite a few decades, don't want to tell you how long, and then moved into the home care space about 6.5 years ago with Home Instead, now DaVita, and I was the managing director of one of the offices, Melbourne Outer Northeast. I'm now just acting business operations manager for 5 weeks while the bomb's overseas having a well-earned rest. But when she gets back, I start my proper role in August for DaVita, and it's a national palliative care nurse practitioner role because I'm an endorsed nurse practitioner. So I'm super excited about getting my teeth back into palliative care because that is my first love. One of the things that really struck me when I moved from specialist palliative care, community care, to aged care was that very few people were dying at home and very few people were having those conversations, and there wasn't a lot of advanced care planning happening. So it's really sort of lit a fire inside me to try to improve on those aspects. It's, much easier when you're working in a specialist palliative care service and you've got a, reasonably defined prognosis because the majority of the clients do have an advanced malignancy, and it's easier to predict than it is in aged care. But I think we can still be having those conversations so much better in aged care. People tend to have an acute event, go to hospital and never come home again. And, the things that once they get into hospital, the hospital staff are saying to them, you're too sick to go home. And I always hate that. It used to happen in specialist palliative care as well. If you've got the resources and the support, you can go home and die at home in most cases. Anyway, so that's where I'm, really wanting to make a difference with DaVita, and I'm really excited that DaVita have a passion for palliative care as well, and really want to provide the best palliative care support they possibly can to their clients all over Australia. And as you alluded to, Tiffany, it is a bit of a sorry, phone call coming through. It is a bit of a postcode lottery, as we know, and DaVita have 49 offices around Australia, and they're in metro, regional, rural areas. So it's going to be quite a challenge to develop a model that's flexible enough to support people wherever they are in that postcode lottery. So, so my new role will be to try to develop that sort of model for non-specialist sector to be able to utilise that funding as well as we possibly can for our clients. We already provide palliative care training for our caregivers using the LDAC models. And I'll be reviewing all our training and developing modules as well for our care managers and our clinical staff, because I think that piece of the pie is missing at the moment as well, because our care managers really need to be able to identify the deteriorating client as well. So then we know that not all caregivers, well, we call our care workers caregivers, we know that not all caregivers actually want to work in the palliative care space. For some of them, it freaks them out, the thought of it. Same with some nurses and some doctors and allied health don't want to work in palliative care. It's a choice. But we do have a lot of caregivers that do want to work in the palliative care space. So my plan is to build up a core group of caregivers who are highly trained in each of our offices around Australia, so that when we do have a palliative care client come through requiring that support, we'll have a core group of caregivers that we can call on, that we know are trained, that we know are comfortable in the palliative care space. So that's one of the things that I've started to think about. Fortunately, I really don't need to reinvent any wheels, because there are so many fantastic resources out there already. As we've talked about today, LDAC, Care at Home, Care Search, the peak bodies for palliative care, Australia and estate bodies, Palliative and Pepper, there's so many resources out there, but I think sometimes the generalist services just don't know that they're there, even though I know the programs spend so much time getting the word out there, but the services are so busy with a million other things that they sometimes forget about these fantastic resources that are there. So my idea really is to package up these resources for each office around Australia, depending on where they are, and then link them into their specialist community services, if they exist, where they are. And because we know that even the specialist services work slightly differently around Australia and even within a state, so we need to know, how their resources are, what their referral criteria is, and then make those links so that we know what we need to do in each office. So it's a fairly big job to be able to do that for 49 offices, but I'll do my best. We'll make a start on it in August. So I'm super excited.
No, thank you so much for sharing. I think it's really satisfying to hear that there is a very considered approach for rolling out that kind of delivery of palliative care. And it's reassuring that I think for most of the sector, it's not a money grab. It's not people like looking at end of life care funding and seeing dollar signs. They're seeing a lot of work accompanied with that. And I think that it's having that knowledge of what is involved to support the sector, support staff, and really acknowledge that palliative care is not their specialty. Their specialty is aged care, and the palliative care aspect will be challenging for some staff over others. And that is something that when we're looking at developing teams, we do need to be mindful of and meet everyone where they're at. Thank you very much. Tony, in preparation for the new Act, LDAC have released their own guide for the preparing for the new standards. What does the new guide include, and how does it help services prepare for outcome 5.7?
Thanks, Tiffany. And I love what you're saying about meeting services where they're at, because that's the premise behind a lot of LDAC's evidence-based resources. We encourage services maybe who aren't ready to go on a full LDAC linkages journey to tap into our newly revamped website. It's had a bit of a redesign recently to help services and individuals search for role-specific or practice setting-specific resources, as well as our interactive care models. So it might be that it's certain different elements that you might want to engage with before embarking on linkages, but the Aged Care Service Guide is one of our newest tools, and it recognises, again, that you mentioned before, Tiff, about palliative and end-of-life care being recognised as core business for aged care, and the new standards acknowledge this responsibility through Standard 5. Those three statements, those three outcome 5.7 statements relating to palliative care and end-of-life care, are really about noticing early when things change, opening up space for conversations about a client or resident's wishes, and providing care that's compassionate. So understanding the intent behind the outcome really helps aged care services align their actions. So part of the guide does a little bit of that, really understanding what that means for home care and for residential aged care providers. And the guide was developed to really support services, as Danny was saying before, around that demonstration of those three legislated statements. So a lot of our services are already providing care in multiple ways and in different levels. Some might be starting this journey for the very first time. So this guide is fairly broad in that it does highlight under each one of those outcome statements what are some specific LDAC evidence-based resources that could help you. So it also includes a really handy activity checklist that offers clear steps that services can take to strengthen their approach to palliative care and end-of-life care. And under each of those three outcome statements, it highlights which resources might be best to leverage to support services and meeting the expectations. So outcome statements 1 and 2 are really, as we know already, recognising and addressing the needs, goals and preferences of individuals for PAL care and ensuring that pain and symptoms are actively managed. So for these statements, the LDAC care model is really a great place to start. A lot of services use it as a way to organise their framework to care, as well as helping staff to understand how residents or clients' care needs will change over time. It helps really proactively put in place that working together element, but also the importance of person-centered care planning and provision that respects and reflects the individual's dignity and choices, even as their needs continually or evolve or change over time. Enrolling on the linkages program, as we've just mentioned before, also really helps services connect with other specialists in PAL care and primary care, but also helps them hone their generalist skills in this space. It's helping them to work together to deliver comprehensive and respectful care, but we do work with you to tailor your own quality improvement plan. So that's based on individuals. As we mentioned before, there is a great deal of variance even within the state. So depending on who you're connected to locally or who you have access locally, we work with you to find a plan that works for you and identify any learning needs and how we can connect you with the likes of other national palliative care education providers, the likes of PEPA and PCC for you. Additionally, using the organisational audit or after death audit tools or the personal leave learning assessment can help review policies and processes and also identify any staff learning needs. Our evidence-based toolkits and common clinical tools really help with the assessment of pain and symptom control, and have also links to other education and information on how to conduct things like case conferences, family meetings, and strengthen those referral and communication pathways. And finally, the third statement is all about ensuring the support of individuals, families and carers, and those working with individuals with life-limiting illness. So it's here that the Talking with Families resource that HealthLex recently also launched can really help aged care staff build confidence in initiating those conversations with individuals. These packs come at both a service level to protect the right space and environment to have the right advanced care planning and care planning discussions, as well as fact sheets that can help and be shared directly with individuals and their families to understand what matters most to them. And finally, the self-care room emphasises the importance of enabling and supporting and encouraging staff with self-care. It has a range of resources to support the emotional wellbeing for those caring for older people at end of life. And I will just mention just again that the Linkages EOI is now live, so we are currently accepting new applications for any services who might be interested. And as well as the resource itself, together with the other products that I've mentioned related to the resource guide, very easily downloadable on our website. And to tomorrow we've got a webinar being hosted by Professor Deb Parker. She's one of the 3 program leads. It do go into a little bit more detail on some of the specific LDAC resources and how they can address your service in meeting the expectations of outcome 5.7.
Thank you very much. It is a fantastic guide. We have been showcasing it at both Aging Australia's Day Conference this year and through our channels. And we do find it is that all-in-one package of, if you are a service and you want to meet the standards, this is ABC. Lucky last to lead us out, Danny. So one of the significant changes being introduced in the new Act is the co-contribution requirement for people. While we understand that these costs won't apply to clinical care, we do know that people receiving palliative care do have increasing personal care needs, which do incur the co-contribution costs. How can we better prepare the community and our services for these changes, and what would this look like in real time for us?
Yeah, this is such a good question. It's a little vexed at the minute. I think if I say it like that, that would be putting it nicely. I think for, I'm sure for people like Karen, that would be vexed is a nice way of putting it. I think what we can start with, though, as for us that are leaders in our industries and how we interface with community, and for people that are on the line, I know many of you will be doing this now. It's really important to emphasise, I guess, what is included in. So when don't you hit like those co-contribution elements, because there's a lot of stress. And so I think at the minute, if we say that those nursing and palliative and allied health areas are funded, this is important to understand, especially when you're looking at that palliative care journey. I just wanted to also say that I think it is fantastic that we've got people like Karen that are nurse practitioners that are entering the system, and we are seeing in an increasing leadership capacity, because I think those roles are very important, and the fact that they can are being very much recognised by government in just a new way is very important, with guiding us through, and their voices in these areas of even explaining, which I'll get to a little bit, is, well, when is personal care, but when is personal care really deeply informative for how we review and look at the individual, especially as you might go, well, hygiene at one time is maybe just very straightforward, but in the palliative care journey, it can be very key in determining what needs are met and not met. So I'll touch on that a little bit more. Now, with it, yes, you are right, Tiffany, to touch on that personal care and domestic support is attracting means tests, but only for those that are in a position to pay, and there are hardship provisions. But I would be remiss if I didn't say, at the Senate inquiries going into the Aged Care Act, personal care and toileting were very, very vexed as issues to go, well, is it appropriate that they are not, that they're included in that sort of just domestic area? But at the minute, again, it would be important for people to know only people that have means and capacity will be asked to contribute to those. But I understand that it's not completely straightforward. But on average, the government pays around 95% of costs. And I guess at a little bit more at a granular level, what does that look like? Well, for every dollar that a person contributes, the government, again, on average, contributes $7.8. So I think if we really highlight some of those stats, and that's the taxpayer, so that is really us that are making sure that we prioritise aged care and contribute. Now, in the residential environment, it is a little bit different, and this is why you're probably seeing people struggle with this co-contribution element, where people would go, well, toileting and hygiene, all of it, that's clearly covered under ANAC. And so why have we got a confusion in I guess, the way we treat and manage certain aspects just based on environment, and that would be the home versus residential. So I think even for us at Ageing Australia, we feel that there's a lot still to be said, and prosecuting the case of where toileting and hygiene fits in. And again, back to that Senate inquiry, that was a very prominent issue by the providers that presented at that, and a number of home care providers and residential providers commented on that as well. With regard to even the co-contribution and the element of going, oh, well, that's okay in residential because all of it's meant to be covered under the ANAC funding, we wouldn't say it's even rolling out as simply as we would like, even in that environment either, because all of it goes through the gatekeeper in that assessment process. Someone has to go, good, we deem that you're going to submit to us that whether it's in residential or home care, you believe someone needs that palliative, but then it's that gatekeeper model to go do, once you've submitted your data, that some people, and I think Karen's already spoken to already, so I won't go over, that now someone's got to now agree with you. There's times when we're saying as an industry, we feel this is somewhat concerning, and as the peak, we find that concerning. We probably are not fully understanding that if we've got nurse practitioners and doctors able to determine when someone is entering end of life, why are we still going through that assessor model? We sort of really believe by virtue, if someone passes away in 3 months, well, they've passed away, they've died, then that in itself is a demonstration. Potentially, if someone doesn't, then maybe we could look to recoup funding or government, but we're going, so for that, that's a bit of a concern for us as well. So even that co-contribution element's not quite evenly treated in exactly the same way in both environments, because we would have that toileting hygiene in aged care, differently treated to home care. But having said that, both still attract a gatekeeper model for someone to even agree that you're at a different level of care and a different standard of care. The reason that concerns us a little bit as a peak is we go, that's different to if you go to an emergency department and someone simply says, well, hold on, you're there. Of course, we now need to treat you. You do need the care. You've arrived. Where in residential and home care, someone could still identify that you have a need in care, but you don't actually enter the system actively. There's those substantive wait lists, which is a little unusual as well. In terms of what we would say is that we would want it, I guess, understood that there are technically no out-of-pocket costs for end-of-life care, so those high-end clinical needs, and Karen's also discussed that palliative care option, particularly important for people that haven't fully entered the system and then want to utilise it, and there are caps for contributions. But again, understanding that yes, for full pensioners, we've got them covered, but there's still means testing along the way. But that again, we are hearing very clearly from people that hygiene and toileting element, well, how does that look? So you might have a nurse that's come in and attending to all your high-end clinical needs, but how does that work with the hygiene and toileting element? So that's definitely a concern. So I think we would say that from our point of view, there's still quite a lot to do as the peak with that. So yes, we acknowledge that there are safety nets. Yes, we fully acknowledge that we are clearly identifying that palliative care is an area that is deeply important to our community. So the Australians have, with their voices, said loudly that they want this managed. They want aged care and the palliative experience as a priority government reform piece, and they voted with that accordingly, and they wanted money spent on it. But we are currently experiencing a little bit of a disconnect, because if you are palliative, but you need someone to come in and tend to your hygiene and toileting, which inevitably you will do in the home, why does that not look exactly like the way it does in residential care? And there is a significant disconnect with that. So I appreciate for people online today, that's not an easy resolve. We would still say that, yes, there is very good coverage for people that are full pensioners, and there are hardship elements as well. But we understand that there's still a significant group of people that have concern about what that would look like. And as the peak, we are regularly prosecuting that case as well, because we recognise that's a concern. I don't think that's a nice, easy way to end. And I'm sure you probably want to end on a slightly bigger high, but I'd say it's still a work in progress. A very large push forward from the community, and that then was heard by government, and then that was heard by reforms, but still more work to do.
I know in the interest of time, we probably won't get to many questions. So from that, I guess I would turn to each of the speakers and just give you 30 seconds to share the one thing you want us to take away each from today's discussion. But before I do, in follow-up just to that point you've raised, Danny, because it is quite a sticky issue, and we do have some incredible leaders in the room, or we have people who know incredible leaders. How can we better support these discussions? How can we demystify things, make it easier for the services, make it easier for the community, and actually get the act and shape of what we want it to be?
So is that for me, that one?
I'll let you answer that bit, and then I'll let you start with the final messages.
Okay. I think for me is just to really get that 1 minute elevator pitch down for any time you come into contact with what I would say is a politician. We of any description. We would regularly hear people say, oh, but do I have a voice? Will anyone listen to me? And when you get that 1 minute, you've got to make it really easy. Presume the person has no understanding at all, and you would be shocked at how powerful that is, but who's even connected behind the scenes. So we would say, and it's not agitation, we would say it's education, and it's very effective advocacy. So it's really simply just saying to Mary, Bill or Bob, when you get them, to go, we're very concerned because so much of palliative care is still giving hygiene, is still attending to someone's toileting with dignity, and we're very concerned that they simply will not be able to do that, or worse still, they'll cut corners. Now, any way you can make that to one of the people that you care for, even better still. So if you can do that in 1 minute, but just keep refining what that would look like, so that then when you get that opportunity, it's really easy to do. So we'd say every single person in the room, reach out to every MP in your area. That's what we would say.
Cheers, Danny. And in 1 or 2 sentences, what are your final messages to our audience today?
I think everyone can take away, and this might feel just a bit too upbeat, but what an incredible time that we've got palliative clearly back on the agenda where it belongs. It was, for those of you, many, many moons ago. Like for me, I've been in health for 35 years and aged care 25, that I'd go, it was. And then I think we went through a bit of an interesting period, and I'd go, the fact that it's back as an accreditation piece with its own outcome tells you that people are going, it matters to us. So a kind of positive.
That's brilliant. Tony, what are your final thoughts?
I think from my side, it's empowering the amazing aged care services that we work with to have a seat at the table, to not be shy and reaching out. There's no such thing as a silly question. Get connected, get linked in with the right team, the right specialist palliative care team, the right GP conversations, and because all of that will make for a richer care experience for both families, for both residents and clients. And I would say that it is a wonderful time to show that people are already doing incredible things. This is more around just enhancing, like the strength and standards. We're just strengthening that incredible work that services are already doing. And I would say engage with LDAC. It's government funded, it's free to access, it's easier to access the right resources now. And no matter how ambitious or how conservative you want to be, there's a resource that will suit you at wherever you are in your quality improvement journey, delivering palliative care and end of life care.
Fantastic. Thank you so much. And just to lead us out the door, Karen, your final thoughts.
Yes, well, try to be a glass half full person. So I recognise that there are going to be a lot of challenges in using this end of life funding in supported home. But I believe it's a beginning. And as Danny said, it's putting palliative care back on the agenda. And I really would advocate for services to really document well what happens when they're trying to utilise this funding. What are the challenges? What's working well, so that we can go back to government and say, thank you very much, this is great, but this is what we need. We need more of this or whatever. So just think about really keeping some stats and some documentation around how this is working in the future.
Brilliant. In the interest of time, we will come to a close. I do appreciate we've not had a time to answer questions, but what I would encourage everyone who has questions, please email them through to me. I will touch base with our panelists and we will have them answered, and we will send them out through a email to everyone so that answer and question are transparent. Recordings will be sent to everyone, as well as any resources that have been raised through this discussion, and we will also send information about our upcoming webinars, both the LDAC one and the one through the Victoria Palliative Care Consortia. Thank you for your time this afternoon now, and we appreciate everyone coming. We will see you at our next meeting. And
Thanks,
big
Tiffany.
thank you to our speakers.
Thank you, Tiffany.
Pleasure.
Thank you,
Bye.
Tiffany. Thanks.
My pleasure. Bye-bye.